Okay. Okay. So anyway, thanks to everybody who has joined. And yeah, to all of those who are maybe watching later on YouTube or on one of the other channels that we have. I really appreciate it. And what I would like to do for the next few sessions is just concentrate on simple ECGs and just how to look at ECGs and just to get our mind back into managing and reading ECGs and things like that. So the doctors who are on the chat, you're more than welcome to ask questions at any point and stop me at any point, but let's take it further from there. Okay. So what might be easier for the doctors on the chat, if they have any questions, you can just put it up on the chat and then I can answer from there. And if you want to speak as well, that's perfectly fine. I don't have a problem with that either. So I hope that's okay for everybody. So this won't take us very long. It's a relatively short topic, but one that a lot of people seem to have a bit of problems with. So yeah, hopefully it's something that people will be able to pick up on. So what we have here is this is the history of the patient, right? So we have a 63-year-old patient who is presenting with palpitations, weakness, and dyspnea. So if you were to just get a patient like this, of course, the palpitations would probably prompt you to do an ECG, and to see what's going on. So instead of looking at a full ECG, I thought it would be easier just to look at the rhythm strip. Sorry, I just want to bring up the pointer. It's just having a bit of trouble following otherwise. So I'm just going to do it like that. So yeah, so this is our ECG rhythm strip. And if you were to see this rhythm strip, of course, it would get you worried. And, if you could make a diagnosis, great. But if you can't, we'll try and figure out how to get to a point of diagnosis. So when we're looking at a rhythm strip, so I just want to hopefully just type it in here. So the first thing that we look at is the P wave. Okay. So let's just type that in there. So the first thing we look at is the P wave. And the P wave basically tells you about the atrium. So how is the atrium functioning? Is the atrium functioning properly? Is the atrium always functioning? And things like that. So that's the first thing, all right? Then the second thing that we look at is the PR interval, okay? So the PR interval is basically telling us after the atrium contracts, how long is it taking for that signal to get to the ventricle? All right. So that's number 2. Okay. Number 3, what we're looking at, sorry, let me just get it in there, is that we're looking at the QRS complexes themselves. All right. So if any of this seems, odd or you lost in the terminology, and not necessarily the doctors are on now, but anybody later on, you can always go back and have a look at the very basics of the ECG that I cover in another section, and that should help as well. But the QRS complex, what we're looking for in this case is we're looking as to whether the QRS complex is thin or thick, all right? And the thing that we figure from that is when the complex is thin, as a general rule, it means that the signal from the SA node or the atrium is reaching the ventricle. And when it's thick, the general rule that we give is that it's not. So in other words, there's something that's sort of preventing the signal from going from the atrium to the ventricle. Okay. Then the next thing we look for is there a P wave after every QRS, all right? I'm sorry, this would probably be just the longest part of everything, just to set a basis, and then we'll go a bit faster from there. So what we're trying to say is that does the ventricle contract after the atrium? So that's the fourth thing. And then the fifth thing we look at to determine rhythm is sorry, let's put it like this, are the PQRS complexes regular, right? So in other words, okay, we have an atrium that contracts, that's number one. The atrium and the ventricle are contracting at a good rate. The ventricle is receiving its signal from the atrium. The ventricle is contracting after the atrium, but are those things occurring regularly as well? So these are a few things that we look at. So what we can do is that we can actually superimpose that onto this ECG rhythm strip that we see over here. So let me just get back to that. So the first thing that we're going to look at over here is if we can see P waves, all right? And, even on the chat, or if any of the doctors want to jump in, they're more than welcome to. It's not a problem. So the first thing that we notice is that there's no regular P waves. So when we follow each one, we can see what looks like maybe a P wave. Then we see there's nothing, maybe a P wave, maybe something, but what's going on? It's changing its shape. Are there two P waves here? So it doesn't really look like we have a regular P wave. Are these T waves? What's going on? So that's the first thing. So we can't say that we have a good P wave. So our atrium is not functioning properly. That's the first thing that we can see from this. The second thing that we look at is the PR interval. So because we can't make out what's a P wave exactly, I mean, is this a T wave? Is this a P wave? Is this a P wave or is that a T wave? We don't know. So we can't talk about the PR interval in this case. And we look at our QRS complexes, they are actually thin. So that means even though we can't make out where the P wave is, the atrium is functioning and the atrium is sending a signal through to the ventricle. So the ventricle is not functioning on its own. The ventricle is receiving its signal from the atrium. That's why it's thin. And then we look at the complexes, are they regular? Now, if you look at this, you can actually see that they're quite irregular. So we have a wide space, thin space, thin space, thin space, wider space, thin space, slightly wider, more or less the same, more or less the same, slightly thinner, slightly wider, slightly wider. So I don't know if anybody would like to venture a guess as to what's going on with this patient. The one thing I can tell you is that on this particular patient, if you were, for instance, to look at your SATS monitor or your ECG monitor, you'd get very odd readings as far as your heart rate goes. So you'd get a heart rate that suddenly shows up at, for instance, let's say 150, and then will drop again to about 100, and then may pick up again to 160, and then go even higher possibly, and then come down again. So you have this very irregular heartbeat that's there. And even if you were to physically feel the pulse of the patient, there would be a tachycardia, of course, but it would be a very irregular tachycardia. And it would be what we call an irregular tachycardia, because there's no pattern to it at all. It just keeps on moving, in its own pattern. So there's a few things that it could be. There's a few things that cause the atrium to give us a very odd look here, and to also give us a signal that is passed on to the ventricle. And the most common ones are the atrial fibrillation, atrial flutter, and there's less common ones such as multifocal atrial tachycardia. But in this case, and in fact, if we're going to go to the next slide, what we'll actually see is that we've got a case of atrial, oh, sorry, let me just this off here. We've actually got a case of atrial fibrillation. So this is what we are seeing over here with the ventricular rate that they've put at about 128. Sorry, let me just clear out that there. Sorry about that. Okay. So as I said, the patient has a narrow QRS complex and what is an irregular tachycardia. And the differential diagnosis includes atrial fibrillation, atrial flutter, with variable conduction, but that's something a bit more in depth, and multifocal atrial tachycardia. But given the absence of distinct P waves or flutter waves, which is something hopefully we'll see in the future, the diagnosis of atrial fibrillation is the most common one. That would be the one that comes up over here. So I just want to go back and just give you a look. So the common misconception amongst a lot of people, and I just want to draw this out, hopefully I will be able to, is that if you have, sorry, let me just get a nice, if you get atrial fibrillation, that it must sort of look like this. You know, it must be a jagged line that you can't make out anything. And then you get a QRS complex, and then you must have a jagged line again, and then another QRS complex. And, you know, that's basically what it must look like for it to be considered atrial fibrillation. But as you can see here, you know, we've only got what would look like atrial fibrillation, maybe in about one or two areas. And the reason for that happening is the fact that most of the P waves are hidden. So you don't actually see the P waves, or you don't see the fibrillation, sorry, because they are hidden behind the QRS and these T waves that have come up over here. Now, there's lots of reasons why a patient may present like this as compared to the normal presentation that we are used to seeing, but just keep in mind that it can happen. So the AFib doesn't always present with the tachycardia. Very good question there. So there's two types of atrial fibrillation that we get. So we get slow AFib and we get fast AFib. Now, in this particular case, we're looking at fast AFib. Now, slow AFib is a less common variant that we do see, but it does occur. The management is slightly different. I'm trying to stay away from slow AFib in this particular one. The reason being I'm trying to stick more to the basic ECGs, but that's a very good question. There are the two types. And in slower AFib, it's much easier to make out what it looks like. So what happens is that in slow AFib, you'd get this sort of a fibrillation line, all right? And then you'd get your QRS complex, and then you'd have a nice you know, maybe 4 or 5 blocks, and then you'd get another one again. And it can also be irregular, but it tends to be slightly more regular than the one that we see here. So it's not to say it's completely irregular, but it tends to be slightly more regular than what we see in fast AFib. However, working in emergency departments, it's much more common to see a fast AFib, but very good question. Very good question. So let's move on from here. Now, these are the causes of atrial fibrillation. It's not important to remember this right now. This is the type of thing that a person can screenshot and possibly try and learn off and things like that. But I just wanted to point out a few of them to you. The most important, of course, being infarctions, valve disorders, heart failure, and then cardiomyopathies are quite common. Structural are not as common. We don't actually see it there. Congenital heart defects, hyperthyroidism is also a common cause that we do see. COPD, diabetes, excessive alcohol, and caffeine consumption, generally you won't see in an emergency department in an acute setting, but it can happen. The other common one that we often see is due to hypokalemia, surprisingly. It is one of the causes of an atrial fibrillation. So it's just something to keep in mind when you see an AFib. The reason why I mention that as well is because when you get a patient in the emergency department, which is what we are concentrating on now, you can't, for example, confirm that the patient has a heart valve disorder or has cardiomyopathy or has any of these sort of immediately, But the ones that you can do are your cardiac enzymes. You can, of course, get a chest X-ray to look for infections. These would come from your general look of the patient as well as their history, but you can check very quickly for electrolyte imbalances. Now, if you're unfortunate enough to work in a hospital like some of us, it might be a bit difficult to get your potassiums because we don't get it on our ABGs now, which is a cost-saving method, cost-saving effort, but unfortunately maybe costing people their lives. But anyway, that's besides the point. But just to let you know that if you see AFib, consider that it may be a potassium problem. The reason why I mention it as well is because you may say, okay, but I can test for the thyroid. It's true, but TFTs generally take a little bit longer than a potassium level to show up. To get them back from the lab, depending on where you're working as well. So, okay, you've made the diagnosis of AFib. All right, very good. So you don't want to be the type of doctor who makes a diagnosis, but you don't know what to do about it. So what should we do in the emergency department in the case of atrial fibrillation? Now, before you decide on definitive management, the first thing that you need to know with AFib is how long has the fibrillation been present? And the time frame that we use is 2 weeks. Now, majority of your patients will fall into one of these two categories. Number one, the time cannot be determined. So in other words, we don't know exactly, when the person's symptoms started, and we suspect that it has been present for more than 2 weeks. But the majority of them will fall into this where we cannot determine for sure when the atrial fibrillation started. Now, this is not to say you don't get patients where you can say for sure that it's been there for less than 2 weeks. So you may have patients, for example, who have come in for other issues, have had ECGs done. Let's say a week ago, a patient comes, they have an ECG done, it shows a perfectly normal ECG, and now they present to you as our patient presented, and you can say, okay, listen, you definitely have an atrial fibrillation for less than 2 weeks. Once you have that, that's when you consider controlling the rate and the rhythm. So you would do that with things like beta blockers, whatever you've got available. You may use amiodarone, lignocaine, depending on what you have available. But I would always advise that if you're going to do rate and rhythm control in these patients, it should be done, well, not under the supervision, but at least in conjunction with the medics. The reason being that they at least can know what's going on in case they want to take the patient into a high care setting or something like that. But the majority of our patients, like I say, will fall in here. Their fibrillation has been present for a very long period of time, or we can't determine the time at all. So we really don't know how long it's been there. It could have started today. It could have started a month ago. And the thing is, once that happens, one of our reactions is always to try and control rate, to try and bring it down. But in this case, we're actually going to concentrate on anticoagulation. So we're going to use Clexane, heparin, warfarin, some of the newer oral anticoagulants if you're lucky enough to have them available. And there's a reason for that, which I'm going to show you now. So this is an atrium that is fibrillating. And what we know about blood is that when blood stays still or blood is not mobile, blood tends to clot, as we see here. Sorry, let me just get that. Sorry, let's get that up again. So what we are seeing here is that we're seeing a thrombus in the wall of the atrium. Now, if you're somebody who is quite good at doing echoes and you can do it immediately, of course, you can look and confirm the presence or absence, and that can also guide you. If you don't have access to an echo or you aren't that comfortable with your echo yet, then you may miss this. And the problem is that once you start to control the rate and the rhythm, so in other words, you get that atrium functioning properly, you're now going to shoot off this thrombus. You're going to turn it into an embolus, and you're going to make this patient either stroke out or, lodge an embolus somewhere else. So that's why I say with the majority of the patients, because we don't know whether they have a thrombus or not, and that's talking in our general settings. If you are lucky enough to work in a hospital that has the facilities where you can do these things immediately, by all means, make sure that whether the patient has it or not, and you can always go and control the rate and the rhythm. But for the majority of us working in rural, semi-rural areas where we may not have access to this, our first thought is actually to make sure that there's no thrombi. So like I said, the longer the AFib is present, the higher the chance that the thrombus is there. So because with our patients, they have a high chance of a thrombus, the first thing would be to get rid of the thrombus. So you anticoagulate the patient. And then, like I say, once you control the rate and the rhythm, you are now increasing the chances of this embolizing. So that's not your first point of call. That's not the first thing that you're going to try and do. The first thing you're going to try and do is make sure that there's no clots. And once you're sure that the patient is well, anticoagulated, their blood tests are showing it, everything seems okay, then you can go ahead and try and bring down the rate and the rhythm. Can it be done concurrently? Yes, it can. It's done in situations where patients are in need of rate control. So this is when you have atrial fibrillations that are extremely fast, that are posing a danger to the patient's life. So, you have a patient now that's going into acute ischemia secondary to the AF. They may be going into severe heart failure and things like that. These are cases where you would anticoagulate and try and bring the rate and the rhythm under control. But this is not the common thing that happens. And it's the type of thing that you generally do under the guidance of a senior doctor. I hope that's making sense so far. I hope I haven't gone too fast, and I hope it sort of makes sense, and things like that. So when we look at this, we need to say, okay, so we know how to determine what the rhythm is on an ECG, but what will we see particularly for AFib? So those 5 things that I had told you about P waves, PR interval, QRSs after every P, the narrowness or thickness of the QRS, and the regularity of them will actually determine the majority of your rhythm disturbances. So the very particular things that you see about AFib on an ECG, there's no P waves, or let's say discernible P waves. You cannot say anything about a PR interval in that case. And you can't say that there's a QRS after every P. And especially in AFib, the signal is getting passed on intermittently. It's not getting passed on consistently. So that's where the problem comes about. But because the signal is getting passed through, you are getting a narrow QRS complex, okay? And it's an irregular rhythm. So if we go back to our ECG that we saw at the start, we can see it fits all of those criteria. We don't have a definitive P wave. We don't have a definitive PR interval. We don't have we can't say there's a QRS after every P, but the QRS complexes are narrow and they are quite irregular. Now, with atrial flutter, which is probably one of the more common ones that's seen let's say similar to this, you'd actually find a flutter pattern majority of the time. And it's very rare to have what they say, which is atrial flutter with variable conduction. It's not a common problem. So, with atrial flutter, it looks very different. And the other one that often confuses people is an SVT and an atrial fib, because both of them don't have P waves. The difference in that case would be you'd have a very similar thing. You don't have P waves, you don't have a good PR interval, and things like that. Okay, I'm going to answer your question now. Sorry, there's somebody waiting in the waiting room. Okay, let me answer your question now. So, asked by one of the doctors, if a patient is known with AFib, but now presents with a bradycardia or tachycardia, must the patient be treated under the greater than 2 weeks or unknown category? Yes, that's what I'm trying to say. So if the patient, in other words, now present, and you must remember the majority of them will present with the tachycardia, palpitations, things like that. Unless you have definitive proof that it's less than 2 weeks old, if you have that, then by all means, you don't have to worry about anticoagulation. If you don't have any proof to say, listen, I cannot say for sure that this is less than 2 weeks old. I cannot say that it's a day old or a month old or a year old. I don't know whether there's thrombi or not in that atria. So that's why your first point of call is always, treating the coagulation status. And the truth is that by treating the coagulation status, you're not putting the patient in any danger. In fact, you're taking them out of danger. Because what it does is give you time to also go and have a look, let's say, and do an echo, whether it be in the emergency department or in a cardiac setting whatever that may be, a high care setting, an ICU setting. So it gives you that bit of a chance to actually see, okay, are they really thrombi or not? Because once you give the patient anticoagulants, it's not to say that all your thrombi immediately disappear. Some of them can be very large and can take quite a bit of time to break down. But it's a very good question. Thank you so much for that question. So that's what I was trying to say. Unless you have definitive proof that this patient did not have an AFib before 2 weeks and or has, within the last 2 weeks, we can say for sure there was no AFib and now there is an AFib, then by all means, you don't have to worry about anticoagulation. You should do it still because there is a possibility that the patient may still develop thrombi, but you can go ahead and do rate and rhythm control as well. But if you don't know, which is where the majority of our patients fall, then you would start with anticoagulation and then look at doing rate and rhythm control a bit later on. That's what I'm saying. So you're not talking about a patient who's going to, for example, let's say get Clexane and be left in a tachycardia for 2 or 3 days. No, you're just talking about a few hours. As compared to somebody, let's say a patient comes in now, and we had seen this patient 3 days ago for another problem. Okay, I'm just getting a reminder we're going to end in about 10 minutes, so I'll try and just speed it up. So, yeah, we saw a patient 3 days ago for something unrelated. The ECG was normal, and now they come back with an AFib and tachycardia. Then in that case, for example, let's say you're going to put the patient on amiodarone, that's perfectly fine, and you're going to give them anticoagulants at the same time, that's no problem. But if we don't know, you'll just give the anticoagulants and then look for then look to control the rate and rhythm after you've done a few more investigations. I hope that makes sense. And if it's not, please tell me as well. I'll try and explain it better. But like I was saying just before the question came, one of the common things that are often mixed up are atrial fib and supraventricular tachycardia. And yeah. Okay, thanks. Okay, at least the explanation was okay. So just to show you how analyzing those 5 aspects of the rhythm can actually make life easier for you. In both, and let's just say an AFib and an SVT, both don't have P waves. Both, you can't talk about a PR interval. In both cases, you can't say a QRS follows every P, but in both of them, the QRS complexes are narrow. The main difference is the regularity. So in SVT, you have an absolutely regular rhythm, and in an AFib, you have an absolutely irregular rhythm. So that's just an example. So, like I say, I hope that makes sense. The AFib is one of the easiest things to pick up. And like I say, management, as far as AFib goes, oh, sorry. So as far as management is concerned, what I would say is that 99% of the time, you don't know whether the patient has the AFib for less than 2 weeks. So to be safe, start the patient on anticoagulant therapy whenever you have available. Please do not give them high dose heparin so that they start bleeding out of their nose and every orifice. That's not what I'm saying. I'm just saying start them on something at least so that they're not in danger. And if you're not sure or how to use what you have at your workstation, ask somebody. That's the thing. The most important thing in the emergency department is not to be able to manage everything, but at least to be able to say, I've picked up danger and I am now going to either escalate it, or if I'm aware of how to manage it, then I'm going to manage it until I can get the speciality involved. So I hope that makes sense. And I know a couple of our doctors joined a bit late, but it's not a problem. We're going to put the entire video up on YouTube as well so that everybody can watch it. And just before it ends, if anybody has any more questions, we've got about 7 minutes left before my free Zoom runs out. Unfortunately, now I don't earn enough to be able to afford the full Zoom that I used to before. And it's actually become quite expensive. It's about 4,500 Rand a year when I was checking that up. And yeah, that's a lot of trips to McDonald's that I'll have to give up. So I'm not interested in getting it. So I'd rather just stick to the free version. But and if everybody's okay and if everybody understands, then we can end it as well. And hopefully on Wednesday, we can discuss another. Well, when I say simple ECG, what I mean is basic ECG is that anybody working in an emergency department should know. So I hope we can continue with that on Wednesday. So I'm not sure if there's any questions or not. I'll just keep quiet for a little while. Okay. If everybody's okay and it was understood, you can just give me a thumbs up and yeah. Let me just see. Yeah. So you can just give me a thumbs up. I can see you on the screen, and then yeah, we can um, call it a day. Okay, thanks, Doc. I appreciate that. And hopefully on Wednesday we can have another session. And like I say, participation not compulsory. If you can't make it, not the end of the world. You can always catch up later. But thank you for those who did join. I really appreciate it. Otherwise, it's just me talking to myself for 30 minutes. And oh, sorry, Doc. We had actually started at a 7:45. For right now, that will be the time. It will be about 7:45. But don't worry, the entire video is going to be up on YouTube, so you can catch it. I'll post it within the next half an hour. It will be up. You can sit and you can watch it then to your heart's content. Don't worry. I know it will be the most interesting video. I'm going to beat Mr. Beast, in terms of views and that. So don't worry. It will go very well. But just so that you know, it starts at about 7:45. It starts at about 7:45. It's just the most convenient time for everybody, and it will be Mondays, Wednesdays, and Saturdays, so that some of you who are working on the weekends can catch 1 week, and then when you're working, maybe you don't have a chance. Okay, guys, I hope you'll enjoyed it. I hope you learned something, and hopefully we'll learn more as the days go on. Okay, all right, keep well and enjoy the rest of your evening. Okay, bye.